Okay, welcome to my presentation on labor induction to reduce cesarean rates. So first let's look at what are the current cesarean rates in the United States. So currently our cesarean rate, although it fluctuates monthly and even yearly, is currently around 33% in the United States. We are one of the highest percentages for developed countries for cesarean rate of delivery. So why is this a problem? Well, according to Clark et al. 2018, they talk about that there's a general consensus among the obstetrical community that the cesarean delivery rate in the United States is too high. That study also believed that this is mainly due to three factors. The first factor being that the lack of technological advances in fetal monitoring. It also spoke to the lack of technological advances in discovering whether or not prenatally a woman would be able to deliver vaginally due to pelvic size or fetal size. So in regards to the electronic fetal monitoring, it can only give us a glimpse into fetal well-being in utero. Clark et al. 2018 states that it is believed that up to 80% of sections performed to prevent infant mortality on the basis of fetal acidosis were performed unnecessarily, and this can only really be judged by the fetal heart rate tracing that is shown on the monitors. The second factor that they believe adds to the increased cesarean rate is the unrealistic expectation of patients in the United States. So they describe the expectation of parents for a quote-unquote perfect delivery with no adverse outcome, and that the U.S. has a culture of blame that exists, and it falls mainly on the obstetrician to prevent any adverse outcomes. And normally you would say, well, this is correct, right? Why wouldn't we expect a perfect outcome in a delivery? Well, deliveries aren't always perfect, and the parent's definition of perfect may not be what would be considered a normal delivery. The baby is going to have some hiccups on the fetal heart rate tracing, or decelerations as they're more commonly known in the obstetrical community, and parents might quickly jump to think that their baby is in distress and push for a C-section. The third factor is the U.S. legal approach to labor mismanagement. So obstetrical care is one of the most highly litigated fields in medicine, and that is because it is very gray. It is not black and white. Obstetrical care is almost primarily based on the opinion of the obstetrician while being guided by evidence-based practice. So here I have written that labor decisions at the bedside are complex and situation-specific. This leads to a difficulty to defend decisions later on in trial. Each decision made could easily garner both equal support and division amongst obstetrical peers. Obstetricians often jump to performing cesareans as the least risky decision for both legal and mortality purposes. And they often will also allow for elective cesareans based on patient preference if given a choice in labor to the patient. So the purpose of this study or this review of literature was to introduce a possible solution to reducing cesarean rates while allowing patients to have control over their labor and delivery experience. So my PICO question is, in term obstetrical patients with no risk factors, how effective is labor induction versus expectant management at reducing the rates of cesarean delivery? So first P, population. Obstetrical patients that are greater than 39 weeks gestation, these would be considered term patients. The patients must be free of risk factors that would require early delivery prior to term gestation. So for I, the intervention would be the labor induction at or after 39 weeks gestation. C, control, would be the expectant labor management, and that refers to basically just following the body's natural course of labor, letting it go into labor on its own and progressing throughout the labor into the delivery as it would do normally without garnering any interventions. And O, the outcome would be cesarean delivery rates. So the way that I conducted my literature search was, it was conducted under the Summon Discovery tool provided by PA College under the library link that could be found by searching under current students and then library. The keywords of elective labor induction were first used to gather articles. The search was then widened to include all articles relating to labor induction, not just elective, when it was found that it was a little bit more difficult to search just solely based on elective labor induction. The search was then narrowed to include only articles that were peer-reviewed and scholarly within the last 5 years. The prospective articles were then narrowed to only primary research articles, as this would provide more insight into current practice and evaluation of effectiveness of induction on reduction of cesarean rates. And I did put that this article search proved difficult because obstetrical care is an area that is not commonly experimented with due to the increased risk for both mother and baby. Most patients are also unwilling to sign up to participate in studies, especially experimental studies, with their obstetrical care. So this is my literature synthesis. So I have listed all 5 articles here. So we're going to go one by one, and then I'll talk to you about the question that they were proposing, the methods, and then any outcomes and their significance. So the first one was Sinke et al. 2018, elective induction of labor at 39 weeks among nulliparous women, the impact on maternal and neonatal risk. So the question that they were posing was to compare the effectiveness and results of maternal and neonatal outcomes with labor induction versus expectant management in term patients. So the method was the study used a Monte Carlo microsimulation model to represent 2 health systems. Baseline statistics were used to calculate results via software depicting the statistical likelihood of correlating results. And the outcomes were the outcome of cesarean rate was statistically higher at 35.9% in the expectant management group compared to 13.5% in the induction group. The significance of this study was that the results of this study, while significant mathematically, were not performed on living participants and therefore do not carry much clinical significance. So this might be a reason to then perform a clinical study in real life, but this should not be used to say, yes, we should make a practice change. The second article, Miller et al. 2015, elective induction of labor compared with expectant management of nulliparous women at 39 weeks gestation. So let me just tell you, nulliparous women means this is their first pregnancy. They have no other children. So the question that they posed was, does elective labor induction in term nulliparous women with an unfavorable cervix reduce cesarean rates? The method is a randomized controlled trial of 162 women. 80 women were in the expectant management group and 82 were in the induction group. The induction group was induced following an induction protocol within 1 week of 39 weeks gestation. The outcome, the cesarean rate in the induction group was 30.5% as compared with 17.7% in the expectant management group. The results of this study show that induction, when coupled with an unfavorable cervix, which is a Bishop score less than 5, may result in higher cesarean rates in nulliparous women. The third article, Groman et al. 2018, labor induction versus expectant management in low-risk nulliparous women. The question, again, to evaluate perinatal and maternal outcomes of induction versus expectant management in nulliparous women at term gestation. The method was a multi-center randomized controlled trial. 6,106 women participated in this trial. 3,062 were assigned to the induction group and 3,044 were assigned to the expectant management group. And again, an induction protocol was followed. The outcome was the cesarean group, the cesarean rate in the induction group was 18.6% as compared to 22.2% in the expectant management group. Again, the significance, the results of this study show a significant decrease, according to the authors, in cesarean rates for those who opted for an elective induction. The fourth article, Jamovsky and Bergella, 2016, a randomized controlled trial of prolonged second stage, extending the time limit versus the usual guidelines. The question was, can extending the length of second stage labor decrease the incidence of primary cesarean delivery in nulliparous women? So this was a study that was not so much about induction, but more about patients who, whether they were there for expected management or induction, given extra time in that second stage of labor, which second stage of labor is defined as the time that you are completely dilated. So basically you start pushing until the time that the baby is born. And a normal length of time given till we say arrest of descent, meaning that they cannot get the baby out in a non-medicated, non-epiduralized woman, we would give them 2 hours to effectively push. In a epiduralized patient, the typical standard is to give them 3 hours to push. So this was a randomized controlled trial, nulliparous women between 36 weeks gestation and 42 weeks gestation, so a much larger, broad spectrum of gestation there. 70 women were randomly assigned to the study. All had epidurals. Women assigned to the extended group were given an extra hour to push. The outcome was the rate of cesarean delivery was 19.5% in the group that was given an extended amount of time versus 43.2% in the usual labor group. So the outcome of that was that allowing women that extended amount of pushing time decreased the rate of cesarean delivery by more than half. And so the significance of it would be that this study suggests that more time may need to be given during second stage to decrease overall cesarean rates amongst nulliparous women. So again, this is their first child. The fifth and final article was Walker et al. 2016. It was a randomized trial of labor induction in women 35 years of age or older. The question is to evaluate how labor induction of term AMA or advanced maternal age patients would affect cesarean rates. The method was a randomized controlled trial of nulliparous advanced maternal age women. Women were randomly assigned to either the induction group or the expectant management group. 619 women participated. 304 of those were in the induction group and 314 were in the expectant management group. The outcomes were that the rate of cesarean delivery was 32% in the induction group and 33% in the expected management group. The significance of those results shows that this study shows no statistical findings related to the advantages of induction on the reduction of cesarean rates amongst nulliparous advanced maternal age women. So where do we go from here? Practice recommendation. So unfortunately, based upon the literature review that I did, I would not recommend a practice change to allow for elective induction in term nulliparous patients. With the articles reviewed, a consistent statistical significance was not found to provide enough evidence that the results could be favorable in everyday practice for reducing cesarean rates. The results were just all over the place. There was no consistency among studies, and none of the studies that I read did the authors feel like they had enough clinical significance that they could say with certainty that they could replicate these results in additional study, and they all suggested that more research was needed. I did, however, find the one article that I examined with a need for extended time in the second stage. The fact that it displayed promising reduction in cesarean rates, I believe that this warrants the need for further research into this topic as a way to reduce cesarean delivery rates in nulliparous women. I think that this is a great place that we could do more research, especially on my specific unit, to see if it would help reduce our primary cesarean rate. These are just the references, and thank you for watching. I hope you all have a great day.